Welcome to this week's installment of the IMAG MSM Working Group on Multi-Scale Modeling and Viral Pandemics seminar. We have two talks today. One is Harry Hochheiser. He's the director of the Midas Coordinating Center, which is a very important organization for us, and there's quite some overlap and connections. Harry gave us, James and me, an opportunity last month to talk to their membership, and then we have Guido España from the University of Notre Dame, who is going to tell us about agent-based models. I think the first few slides are some basic housekeeping. Bruce, can you? Yeah, so this is the cast of characters to keep this going. It's me, Reinhard Laubenbacher, James Glazier, and Jim Sluka, who does all the web administration, and Bruce Shapiro, who coordinates activities, and you've all gotten emails from him. Here's the various communications channels, which, as always, we encourage you to use. And this is a good opportunity for anybody to make any announcements, open positions, Nobel Prizes, various other things. If there are no announcements, then
I have one. Yeah, so hi everyone, I'm Mitchell. I just wanted to, I'm part of the dissemination and outreach group, as well as the lung, pulmonary circulation, and aerosol transport group. I just wanted to give everyone an update that we're working on a white paper. So Chantal is the lead on that. She couldn't make it today. But one of the things we talked about in the dissemination and outreach group is that it would be good for leads and those from subgroups to, publicly come on and say how their subgroups are doing, in hopes that maybe that'll motivate some of the other subgroups. So I did want to just tell everyone that our group on lung, pulmonary circulation, and aerosol transport is kind of in the final stages of a draft for a white paper. And we will definitely share that with everyone once it's in the final stages of that. So thank you.
That's great. Thank you so much. And I know there are some others in the works, and we have periodically, we do have one of the seminar slots reserved for subgroup leads. So let me use this as an encouragement for subgroup leads to tell us about presentations, about things they would like to announce. So that's great. Thank you so much. Any other announcements? If not, then I think we'll just, oh yeah, so here's an announcement, which I forgot, the fifth workshop on virus dynamics. We've sent out information about this several times, so this certainly is extremely relevant, and we encourage you to sign up for it. Any other announcements? Yeah, so upcoming meetings. Next week, we'll have Virginia Paysauer from the ARO Biomathematics program, who will tell us about what her program is interested in. And Tom Lipniaki from the Institute of Fundamental Technological Research in Poland, who will tell us about their research. We have a full house September 16, Daniel Becker and John Burke from Applied Biomath. And September 23rd, we have two folks lined up. So please, if you yourself would like to speak, or if you have somebody who think would be really good for one of these seminars, please let us know so we can invite them as we move forward. The rules: if you don't speak, please mute your microphone so we don't get feedback, etc. And so normally what we do is we do the two presentations and hold questions until after both are done, and we usually add on 30 minutes from 4 to 4:30. Today, unfortunately, both of our speakers will need to leave sooner. Harry will need to leave right at 4, unfortunately. So Harry's going first. So maybe what we should do is as soon as Harry's done, we'll have a little bit of time for questions for him, and that'll leave some sometime after the second presentation. So without further ado, let me turn this over to Harry Hochheiser from the University of Pittsburgh.
Great, let me share my screen here and hopefully this will work the way I want it to. Okay, there you go. So can you see my presentation now?
Not yet.
Okay, hold on. I'm going to get it there. Where is it? I think I would have figured this out by now, but
well, it says that you're started. So
how about that?
oh, there we go.
Okay, perfect. Great. So first I want to just say thanks for inviting me to talk about the Midas Coordinating Center. Really enjoyed hearing from Richard Reinhardt and James last month, and we're going to tell you a little bit about what we're up to at Midas and give you the history and tell you some of the things we're working on. And I think you're hopefully going to see some parallels and some areas of mutual interest here. So Midas is the Models of Infectious Disease Agent Study. And you can see here our mission statement that we aim to advance science to improve global preparedness and response against infectious disease threats through research, training, promotion, and service. Midas has an interesting history at the NIGMS. There was for a while a dedicated funding stream that supported this kind of work, and now that's no longer the case, but we have an active and vital group of 800 plus members, which I'm sure has been inflated by, of course, COVID, which was really been the focus for the past year and a half. But the current incarnation of the center started in 2019 with a new grant from NIGMS, the University of Pittsburgh. And we run this in collaboration with colleagues from the Fred Hutch from Florida, UMass, and Texas. And I say currently COVID, that's been the lion's share of our work for the past year and a half for obvious reasons, but that is not a policy decision so much as just what the community is focusing on. So I just want to say a minute here about the approach that I really think about when I talk about Midas. Having been part of other coordinating centers that have tried to lead and corral researchers, I really try to be cognizant of the idea that we want to both lead by behind and lead by example. We are not about trying to tell the community what they should do. That wouldn't work. We are trying to support and build bridges and build collaborations. And by leading by example, I mean, we're going to try to suggest possible approaches that the field can move forward. And I'm going to talk about some of that in a little bit. But we are not about trying to say this is what modeling research should look like in 2021. That's not up to us to decide. And if we tried, we'd fail. So from that note, just want to tell you a little bit about some of the things that we do. We have a lot of work going on in training and promotion. We've sent students and supported people going to some of these various ongoing efforts that teach folks how to do infectious disease modeling. I didn't mention here, but we also have supported diversity conference where we try to broaden the diversity of the field in terms of getting some trainees from underrepresented groups to learn about disease modeling. We try to present at meetings. We have the monthly webinars that Reinhardt and James participated in, and we really try to bring people into the field. Again, not that that's been that hard to do lately because it's on everybody's minds, but it's still something that is an important part of the coordinating center. In terms of promotion and service, we spend a bunch of time creating data sets and models and tools that I'll talk about a little bit this year that can be of use to the community. We engage with stakeholders to try to translate research into preparedness and response against disease threats, and really trying to have that impact, which of course is what everybody would like to do and is difficult. We're also trying to play a role of building bridges to some of the other interested public health groups. So we regularly have interactions with CDC, with WHO, and of course within NIH. We want to improve the reuse of models and data software, which I'll talk a lot about that. We support high performance computing. So if people in the community want to do some modeling and they don't have the cycles available, we have funds and technical support for that work. Another thing that we're doing is trying to map the community and see who's collaborating, who's working together, what the field looks like. And we've got, we're working on a visualization to see the state of the Midas community and hopefully to learn from that as well. We have an urgent grant program that was funded last year through a supplement that funded several different projects of various sizes. These are just a couple of the examples. I'm going to give an advance notice now that we were going to have another small program with some additional pass-through grants we'll be handing out this fall. So if folks are interested, I'll repeat this part of it, but we encourage you to join Midas if you're not already a member, and then you would be eligible to apply for these grants. Joining is relatively straightforward. Fill out a web form, tell us who you are, convince us that you're relevant and you have relevant research interests, and we'll approve you as members. And then you would be eligible for this funding. And again, I'm happy with any of these things I discussed to talk individually about them later if we don't have a chance to get to that today. We have an annual meeting. This past year was online. You can go here to get a look to this link to see what was covered, but it was a 3-day online meeting. And we are currently in the very early stages of planning for what will hopefully be an in-person meeting in 2022. Location and dates to be determined. I mentioned also the Conference to Increase Diversity in Mathematical Modeling and Public Health, which is hosted together with our collaborators at Harvard. Again, that's probably going to be happening in Boston in January, and it will be focused on trainees from underrepresented groups. And so we encourage participation there. So what I really want to talk about here, which I think is of most interest to this group, is what we're doing with data and thinking about the data that used in infectious disease modeling. I come at this as an informatician with training in computer science, so data is something I think about a lot. And I'm going to make the claim here that for the infectious disease modeling community to think more carefully about data, how it's used and what it means and how it might interact with other data presents many opportunities that could help us leverage the value of the work that's being done. And so along these lines, we're thinking about definitions of what are the data items and the attributes. I don't mention on this slide, but we're also thinking about metadata that I'll talk about soon. Data dynamics and what does the data look like and how does it change is something we're also trying to understand. How do we integrate new data types? And if you pay attention to COVID research at all, there are all sorts of data that people have been tracking that may not have been tracked in earlier outbreaks that I think are worthwhile. And we're looking at all of this to try to adhere to the FAIR principles to say that data should be findable, accessible, interoperable, and reproducible. We're not even close to done with that, but that is the goal that we're shooting for. Particularly of relevance to this group is the notion that a lot of this data is multi-scale. And in that sense, what I mean by multi-scale is really that it covers the macro in terms of populations and case counts, but it could also get down to the micro of individual hosts and organisms and behavior, and to say, what can we do to facilitate bridging the gaps between those scales so that they can inform each other. We do this with the notion that so much of this work is interdisciplinary and collaborative and brings in people from very different perspectives. This is, of course, key to the questions of describing data and how it's used, that we have to bridge the gaps between these different communities. And then this final point of translation, this is a really key point for Midas. We want to have impact on decision makers. And again, there's no better time to do that than now, given the policy and the need for understanding disease outbreak dynamics that we still face. And fortunately, we've had some at least modest successes along these lines that we can talk about in a little bit. So to this end, one of the things we've been spending a lot of time on in Midas is curating data. We've got data catalog of over 250 different resources. A lot of them are data sets that are have been hosted by third parties that we have scraped and curated in the Project TICO format, which is this pre-existing work that was done by Wilbert Van Panwees and his collaborators at Pittsburgh. And I'm showing an example of the search screen for Project TICO, and you can see some of the rich metadata that's going on there. We also have a lot of other data sets that are just publicly available that we've curated and described in a common data model that I'll talk about in a minute. And of course, you've got software that people are using. You've got dashboards with data. You've got repositories of data. And by repository, I mean somebody else's website that has a whole bunch of data, just like Project TICO. And we distinguish between repository and catalogs, which are really just these pointers to other data that might be out there in the wild. And so we're trying to bring this together in a useful format for the Midas community. Not to claim that it is in any way exhaustive, it's not. And we don't have the resources to do anything that would be close to that, but just to try to bring together some data that might be of value to folks. So one of the challenges here that we found, of course, is to try to say, well, what is the data about? What are the topics that are covered in these data sets? And so we built a preliminary ontology, and I put ontology in quotes there from a reason I'll describe in a minute. But we have relevant topics, and what you see on the right-hand side here are as a subset of the different topics of the data that we've curated. This list, again, no claims here to be exhaustive, developed very much inductively, looking at the data sets that we collected and identified as being relevant, trying to describe them, and then group the categories to build up this model that might show what a COVID data set is about. Now, these are not unique in the sense that any given data set may cover multiple topics here, and I'm sure there are things we haven't hit yet because we just haven't come across them. So we don't claim to have a definitive model here, but just a starting model that is useful. I call it an ontology in quotes for a very specific reason, in that one of our partners on this project from Florida, Bill Hogan, is somebody who does a lot of ontology work on a regular basis, and he will be the first to point out to me that this model here is neither rigorous enough nor well-defined enough in terms of the concepts to really qualify as a biomedical ontology. That said, very much the approach here that we're trying to do something useful that is a start and working towards better. So hopefully at some point we can get to removing those quotes and calling it a real ontology. But I believe there is utility in modeling the world of what's out there in this sense. And yes, we could certainly, as with any model like this, argue over the details, but it does give some beginning map to what data is out there and what it might look like, and allow for some comparison between data sets, which is very much the point we're working towards. At the same time, we are also trying to think about metadata for these data sets. How can we describe the data sets to be useful? And I have the quote here from the, with a typo, unfortunately, a quote from the original FAIR paper by Wilkinson et al., where it should be data are described with rich metadata, richly described with a plurality of accurate and relevant attributes. So we need metadata that gives you an important and useful picture of a data set. And so we've given some thought to thinking about what metadata we need for these data sets to make them useful. And we've looked at prior models such as the W3C HCLS dataset descriptor, which was published several years ago, and a metadata specification from the GoFair Foundation and the FAIR data team. It's a group in the UK that have looked at dataset descriptors and what metadata is needed. And again, to try to be FAIR compliant, even though we know it's almost certainly incomplete and unsatisfactory. So to that end, we've looked at these various different metadata fields, and you can see here we have several. Name, the geographic resolution, the title, creator. A couple of points I want to make here is that each of these data sets, or many of these data sets, have a date of start and end. So if you think about COVID data where you're tracking cases, there might be a first date and a last date. We may have data sets that are being continually updated that we need to represent that as well. Publications, curation, the version of the data set, in those cases where somebody gives a version number that is regularly updated, the licensing information and the rights so that people can understand who can reuse it under what conditions, and a few other pieces here that really help us understand what the data is and track where it came from. Now, to that end, we might find ourselves adding some more information here about provenance and tracking. For example, the idea that one data set might be derived from another is something we need to add on to, but we haven't seen that much in the data that we've looked at thus far, although we know it's certainly out there. So we're using these things to build the Midas data portal, which we're hoping to release next week on the midasnetwork.us site. And you can see here that we have the ability to search by country, to filter out it along that top row by the different types of objects, whether it's everything or just data sets or software or dashboards. We are going to have the ability to look at date ranges as well, so that we can say that, say, you only want something that deals with the second half of 2020 as opposed to any dates. So this will be live on the Midas Network website, if all goes well, sometime next week. So I want to now spend a couple minutes talking about the interoperability and reusability aspects of fair data. And this is something else we're trying to think about in Midas, to say, how can we take data that's out there and increase the possibility of interoperability and reusability?
Yeah, 5 more minutes, Harry.
Yeah, okay. And I will zip through. So the idea here is that we have to make sure that everything is interpretable and we have common semantics. So to do this, we're really looking at things like what are the definitions, and the argument here being that when you talk about cases and deaths and hospitalizations or vaccination rates, these things may seem clear and obvious, but they're not. And two different data sets may use these terms in different ways. And so how do we bridge the gap is a challenge for us. Another one is this evolution of data, that if you look at, say, COVID data, you'll see that the case count for October 31st might be one thing on November 1st and another thing on November 2nd, and still a different thing on November 3rd. So how do we understand those changes, and how do we make it clear to people what's going on so they don't run into difficulties? We've got a lot of efforts here to look at combining models. The Forecast Hub was built by Nick Reich, which does short-term forecasts among many groups and finds ensembles. The Scenario Modeling Hub is doing these things for 6 months out under different assumptions of what might happen with vaccines or variants. And I want to build on this model to say that, the idea of taking multiple modelers and having them all look at the same data to find consensus models with confidence intervals is a great way to move towards reproducible forecasting. But it's limited because each model's got to run each group's got their own model, their own code that they run, and they submit results. One of the things I'm trying to think about is to say, how can we take various different models and various different data sources and tools for building reproducible workflows, which we're working with our colleagues in the computer science department here at Pitt with their Occam tool that does reproducible workflows. How can we build a generalizable platform for allowing us to share models, share data, and compare different models with different data sets to see which works well, and use common metrics to come up with a platform that might be usable for the community to really have a workbench where they could use to share ideas, share models, share approaches, and bootstrap the field to be more effective. And this is the goal that I'd like to shoot for. We honestly don't have the funding for this to fully realize this, but I think it's something that we can take some significant steps towards, and we're working on that as we go. And I think this is very much in the spirit of some of the things that Reinhard and James presented when they talked about some of their modeling work, just at a very different scale and with some different approaches. So on that note, I will wrap up. I want to encourage people to join Midas. There's the link for membership, and I'm happy to share these slides later. And to thank the great team that we have at the University of Pittsburgh and the support from NIGMS, who've been really great partners in this effort. So with that, I'll stop. Thank you.
Great, thank you, Harry. So given that we need to wrap up sometime earlier, let's have some questions for Harry before we move to the second talk. Any questions? Maybe while people gather their thoughts, I have a question for you. So the Midas network obviously has been extremely successful, and you have a large membership. Certainly one source of that success has been a steady stream of funding for a long period of time. Aside from that, what other factor would you identify as really the most important ingredient in the success of that initiative?
Well, as I said, I think it's a matter of listening to the community, that we have a lot of people here who are doing great work and working very hard at this modeling and trying to drive things forward. And if I were to try to tell people what to do or try to be too forceful, then I think that would just fall flat. Researchers are notoriously stubborn and don't like to be told what to do. They want people to figure out how to help them and how to magnify impact. So to my mind, I want to listen and use the ideas of the community and the people who know this modeling work well, and try to figure out how can I insert our efforts in a way that's going to multiply the value of what other people are already doing. And I'm always open to suggestions along those lines.
Mm-hmm. Thank you. Any other questions?
Sure. Since I'm sorry I was a few minutes late today. I appreciate your understanding. I really appreciated what you were saying about data organization and findability. One thing that we face with in-host modeling is actually the problem of bootstrapping, not the technical end of bootstrapping, but the practical one, which is until the models exist, nobody collects the data you need to build the models.
Mm-hmm.
Is that something your community has faced, or were the data that were needed being collected already to an extent so that bootstrapping was not a problem?
Yeah, I don't think bootstrapping has been such a problem for COVID research because there are so many good sources of data out there. So for example, the Scenario Modeling Hub really relies on the Johns Hopkins data sets for their counts, and that is what they consider to be the gold standard. Now, if you've looked at this at all, there are many other places you can go to get good data, and these data sources don't necessarily agree with each other. So I could probably go to 5 different sources and find 5 different estimates of the number of COVID cases in Pennsylvania on August 31st, or even July 31st, even a month later. So there are going to be some differences, but they're out. The feeling that, yes, a lot of people have collected this data in some fairly careful ways means that bootstrapping really hasn't been so much of a problem. Now, the question of how do we compare models and how do we learn from what other people have done in a more structured, rigorous way, that's still a real challenge.
I guess NPR had an article this morning about the reporting to the CDC by states was extremely spotty and inconsistent in terms of data annotation.
Absolutely, and that's exactly what I mean. It's not only what fields, what data are they reporting? Again, what is a probable versus a confirmed case? What's the granularity that they're reporting? How often do they update it? And then if you look at any of these sources, you'll often find, on November 1st, 2020, there was a whole bunch of changes as they corrected errors from the past 2 months. And I don't have good solutions for how to get around that, but one of the first things we can do is to be aware of it and understand it at least.
I mean, I was thinking of on our side, one of the speakers we had a few weeks ago was pointing out that the number of available profiles for viral load for individual patients was less than 100. Mm-hmm. And the frequency of data measurement for measuring viral load was also at best once a day, and you can have viral load change by a factor of 1,000 in a day.
Yeah.
And so that even the most basic thing, like how much virus is there in a patient when they're going through COVID,
Yeah.
was actually not well documented. I mean, Alan Perlson has fought this. All the people doing in-host modeling fight it. And so and if you want to connect these kind of in-host models to doing the epidemiology,
You need that information.
you need that information.
Absolutely. Good challenges.
If we think about consumer groups, we look at the kind of modeling we do and say that the clinical community is a consumer target group for us. Your kind of modeling includes decision makers in public health and the like. And the question is, what percentage of your membership is from your consumer groups?
Very little. Basically the Midas membership are researchers working on infectious disease modeling. And that's really by intent and design. Should we be reaching out to people who are consumers and citizens as a scientific community? I think absolutely yes. And more of that, I think, is needed on a number of different levels. We have a couple folks who are involved in the scenario modeling hub who specialize in scientific communication, and they've been very good. And we have had conversations with news outlets as they've picked up on it, but that's really just scratching the surface. And yes, the community could use a lot more of that. And how to do that is not something that we tackled much in Midas, but it's an important problem.
Great, thank you. In the interest of time, we should probably move on to the second presentation. Harry, thank you very much.
Thank you, Reinhard.
The chat has the link to becoming a member, so please do. And if you have any further questions for Harry, make sure you contact him. And hopefully, we can continue to forge some connections between those two efforts. I think it's very exciting. So for our second presentation, let's move on to Guido España from the University of Notre Dame. I'll turn the floor over to you.
Thank you. In the invitation, I would like Midas resources. So it's very.
So Guido, we cannot see your screen.
I don't know. I was having trouble hearing as well.
Yeah, and we cannot hear you.
Oh my! Let me try again. It must be the Wi-Fi. Can you now?
Can you hear us, Guido?
I think I'm having issues with the Wi-Fi. I don't know if someone can hear me.
We can hear you, but we can't see you. Yeah, I guess you're not sharing your slides at the moment. Mhm. Can you hear us? Well, I don't know. Okay. Looks like he's troubleshooting. You're muted, Guido.
Sorry, it seems like I'm having issues with my internet. So I'm not sure if I'm still on Zoom.
You are, we can hear you. Maybe
Okay.
for purposes of bandwidth, if it doesn't work, then maybe you could just mail Bruce your slides and Bruce could share them. But maybe we can try and see if it works.
Okay, I'm gonna turn my camera off just in case that helps.
Yes.
Okay, let's try one more time.
Okay, we can see your slides.
Okay, cool. And if I stay quiet for too long, please let me know somehow. It might be the internet.
Okay.
Okay, so yeah, as I was saying, I wanted to talk to you about our experience this past year using agent-based models to project the impact of COVID-19. And we have actually been using a platform that has been developed by the University of Pittsburgh called FRED, that many of you might already know. FRED was developed in C++ initially to respond to influenza pandemic, but it's very flexible and adaptable. So we reused it to represent COVID with by modifying different parameters related to COVID and implementing all the interventions that have been used at the moment. I'm gonna focus. Okay, so this is just a basic structure of how we are using the model. Basically, the agents are individuals in the population. The way we're simulating transmission is that these individuals have daily activities. They may choose to go to work or to school or to just be around in the community. They might as well be in college campuses or in long-term care facilities that are important for the pandemic. And when one of these individuals meets someone else who's infected, they might be exposed and then they might develop or no symptoms, in which case they might choose to isolate or no. And if they have symptoms, they can also progress to a more severe representation of the disease, and it might finally result in death for some people. Using this structure of the model, what we can want to show here is that infections that occur in one place, they can spread to other places and other types of populations. So for instance, this is a tree of the infections that start in a school, and children here are represented by squares and circles represent, no, children are represented by circles and adults are represented by squares. And the colors represent the places where these infections occur. So you can see that infections that start in school, they can go to the house, infect their house members, and then go to the community overall. So this is just to show that the infections can happen in different places and then can spread throughout the community. Now we have used different data types, and Midas has been a great resource to find parameters. And basically what I'm just showing here is that the severity of disease, it's higher for older people than for younger people. So we have that structure in the model to represent that characteristic. We also assume that children are a little bit less susceptible to infection than adults, although we relax in one of our analysis this assumption to see what the impact could be. This is based on very early studies from Davis and others. Now I'm going to focus in Bogotá, Colombia. We have used this model in Indiana and other states in the Midwest and to participate in the CDC forecasting hub and the scenario hub. But I'm going to focus in Bogotá, particularly because I'm from there. And this has been a very interesting project. So for Bogotá to translate FRED to simulate COVID in Bogotá, what we needed to do first was to build a synthetic population. So to build a population that represents every person in Bogotá that reproduces the demographic and geographic characteristics in the city. That's what I'm showing here, just with the population pyramid. Also the household characteristics, the location of workplaces and schools, and accurate representation of students and workers. We were able to get data from Secretary of Education and Secretary of Health in Bogotá to create this population that's very detailed in the location of places and the population density. Now the mobility in the city has changed since the beginning of the pandemic, and this is important to include in the model as I think we are all aware, because there have been different interventions in the city to try to keep people from spreading the virus at different times. People have responded to these interventions in different ways during the course of the pandemic. This is just showing up to February, but things have changed since then too. And yeah, what I'm just showing here is 2 big lockdowns in the city, one in April and one around August, where we adjusted these parameters, the magnitude of this number of people staying at home, to represent the actual dynamics of COVID in the city. But not just in time, but in space, we have observed that it changes. So for instance, here you can see that there is relative more mobility in areas that are southwest in the city, but as time passes, they tend to homogenize a little bit more. So we first calibrated the model up to December 2020. And at this point, they had only we were actually in the middle of the second wave of COVID in the city. So what we did is that we modified parameters related to mobility, transmission, and the use, for instance, of face masks or the closures of schools to calibrate the model to the data on daily reported deaths. So the model fairly reproduces the time series of deaths up to January. Now, we didn't calibrate the model to the infection attack rate, but there was a sero survey done in the first week of November. And that's what I'm showing in the top right panel, where the model fairly well reproduces those estimates from the sero surveys in the city. We're also able, of course, to show what the reproduction number has been over time. That has changed depending on the mobility and the prevalence of infections. And also, because now we also have this very detailed model, we can also see the impacts on ages and the number of people that has been infected for every age group. So at this point, we estimated that by December, there was around 40%, a little bit more than 40% people infected in the city. We were also able to calibrate the model by geographic variability. So what I'm showing here is 19 different neighborhoods or localities in Bogotá, and how the model estimates fairly well the cumulative number of deaths in each of these localities in the city. So having this calibrated model, we wanted to study what was the impact of reopening schools, because at this point in Bogotá, schools had been closed for almost a year, and they were slowly thinking about reopening the schools. So we wanted to analyze different strategies by giving priority to some ages, for instance, or different capacities in the schools. So what we first noticed is that without any variants of the virus, if we reopen all the schools in January 25th at full capacity, we would still see there's the potential of having another wave of infections. And this is actually the total number of deaths in the city in the top right panel by the blue line. However, the question is, can we minimize this risk? So there was a potential risk, but could we minimize this risk? But could we also minimize the time that the schools are closed in the city? So we evaluated different strategies. The first parameter that we varied was the capacity. So varying from 35 in-person capacity to 100% in-person capacity. The other parameter that we varied was the grades that were given priority. So for instance, what happens if we only reopen pre-K grades, only primary, only secondary, or a combination of them, or of just pre-K and primary, or in the last bar group, that's pre-K, primary, pre-K fixed at 75% so that they have more priority, primary from 35 to 100%, and secondary fixed to 35%, so the minimum. And what we found is that in younger ages, because it's a smaller population size and they also have a different type of contacts, we found that they showed a very small risk in terms of this overall city. In primary school, we noticed that after 35%, there is an increase that becomes a more risk for the city to open only primary schools more than 50% capacity. And similar for secondary, but even a higher impact. And when we mix these grades, we found in the last graph bar here, we can see that up to 35% of primary with 75 secondary and 75 pre-K, 35 primary and 35 secondary, we have a very small risk in the total number of deaths. And when we increase to 50%, it's a little bit bigger. After 50%, it becomes a much bigger impact. And we also looked at the impact of what happens if there's higher mobility, and the patterns are the same, except of course the impact of the city also translates into higher impact of the schools being open. This preprint, it's available online if anyone is interested in seeing the rest of the results. I'm going to talk now about what we did after this part of the schools. So after February, that's when we finished the study. Well, vaccination started becoming a reality. There's also the increasing risk of variants being imported in the country. So we have two new variables to analyze in the model. So what I'm showing here, sorry about all the Spanish in these figures, it's that in Bogotá, we don't just have one vaccine, multiple vaccines have arrived in the city: Pfizer, Sinovac, AstraZeneca, Janssen. Sputnik's there, but we don't really have any Sputnik. And this has changed over time. At the point of around 50,000 number of doses being distributed, administered by day, that's a little bit of the average that we found in the last couple of days of this study. And something else that we included in the model was that we give priority. So we prioritized ages. So older ages, and also we gave some priority to teachers. And we try to make this the more close to the real scenario that we could. Now, new variants are difficult to include in the model because there's not a high resolution data set of the dominance of different variants of the city. So at the point of the study, we basically had to make an informed guess of what variants were circulating and when were they imported in the city. We had access to some limited data set on circulating variants, but it's not comprehensive. Now, what we can see here is that in Bogotá, most of the importation of cases come from the US. That's probably not a surprise. And the number of imported infections have varied over time. These are the ones that are able to capture by the surveillance system in the city. So what we did is that we use prevalence of variants in these countries based on the GISA data set, and this is data that we downloaded from covariates.org. So when we combine these three different data types, what we obtain is just an initial estimation of what would be the timing and of this variant. So for instance, we can see here alpha being introduced in the country in November in 2020. We can see gamma, which is the yellow, being introduced a little bit after alpha, and then we start seeing delta being imported around April 27. Again, this is a guess. This is not what we are actually seeing in the data, but this helps us inform the model. Then we can calibrate the magnitude and timing of these introductions, but we have an initial guess.
You have five more minutes, Guido.
Okay. And with this data set, so what we did is basically recalibrate the model to the daily number of deaths, which is what I'm showing in the panel A. What you can see here is the data in red, how the model is able to calibrate the third wave of infections and what an alternative scenario without vaccination would have been, which is the gray bar. So we estimate with our model that around 17,000 deaths had been prevented by now. What else? We were able to see that our model matched the ICU demand fairly well in the city. But the question is now, what could happen with Delta? Because we really don't have any good estimates of what would happen if Delta is introduced. Now, if you can see, all the trends here are going down. So right now there's very few people in ICUs because of COVID. The RT went down very close to 0.5 and the number of deaths also declined. But what would be the impact? What could be the impact of Delta? So for this, we had three different scenarios: early Delta introduction, a little bit late and much later Delta introduction, which is 30 days more or 60 days more. And what we found is that depending on the timing of the introduction of Delta, the impact would be different because it gives a little bit more of time to the vaccine to have an effect and to protect people. And you can see this in the top panel. By the red line shows the vaccination coverage in time. And the different blue lines show what's the impact of higher mobility, which is the dark blue, and the light blue shows the current level of mobility and contacts, which is already very high. What we can see is that the higher the mobility, the higher the impact would be of an introduction of Delta. And this impact would be much lower in a case of moderate mobility in a late introduction of Delta of 60 days after this is 60 days after our initial estimates. What we are seeing right now, I don't have the data to show you, but what we're seeing right now is that we're not in the early Delta scenario. And we might not even be in the 30-day late scenario, but we could be somewhere in between this to 60 or 30. But there's a lot of uncertainty of what the parameters are for the Delta variant and if it's really going to take over now in the city. Our model has many limitations, but one important one is that all of our parameters depend on the limited availability of data that we have. Our results also depend on the mobility estimates and the level of assumptions that we have of individual contacts. And what the basic conclusions of our study are, well, first, agent-based models can be used to understand dynamics of COVID-19 in a heterogeneous population of large size. There's 8 million people in Bogotá. And well, the impact of a potential new wave that's caused by the Delta variant, it could be exacerbated by increased mobility. But this depends on the timing of the introduction of Delta as well. So thanks. Happy to take any questions.
Great, thank you, Guido. Any questions for Guido?
So I guess I had a question, maybe I missed. So how do you include changes in infectivity during the course of an infection in an individual? Or do you assume that the infectivity of the individuals is constant throughout the lifetime of the infection?
This changes over time during the course of an infection. Yeah, I did not specify that in the talk, but yes, this changes over time.
And how do you calibrate that, or do you?
We're not really calibrating that part of the model. We're using the baseline assumptions of that we're already in Fred in that part. What we're calibrating is the magnitude of that.
Okay, and I guess the same thing about Delta. Are you trying to back out how effective the vaccines are against Delta by fitting to the data, or are you making an assumption about the vaccine efficacy or change of infectivity and then predicting forward, or both?
Yeah, the issue with calibrating it to data with Delta is that there are no Delta. Well, at least we don't have any data on Delta in Colombia right now. There have been few cases that have been captured. So we don't have local data to calibrate the model to. Now, what we do have is estimates of vaccine efficacy against Delta from other places. So what we're doing is that we have differential vaccine efficacy depending on the variant of the virus. So it's more effective against Alpha and Delta, for instance. But we also have differential efficacy by infection, symptoms, or hospitalization in the model.
Right, Ruchira, you had a question.
Yes, thank you. So in this synthetic population models, which are very interesting, there's always a concern that if the granularity is too fine, then there's a danger that with very small counts, it can, instead of being population level, it can actually end up identifying individuals. So what were the minimum counts? Did you have to exclude any locales because they had too few members or anything like that in your model?
Yes, no, we did not do that part. We have big enough areas at the level of neighborhoods that are not easily identifiable, but we also took a sample of the census and kind of scrambled it and then drew from that census to inform the demographic characteristics of each neighborhood. But it's not at such a fine scale that we have the age composition of each household. We have the overall age composition at different neighborhoods, and then we distribute them in the city so that they match the population density of the city overall.
Yeah, you mentioned workplaces and schools and so forth. So I was wondering about like possibly some small workplaces and so forth.
Yes, we did something similar. So we have a list of all the workplaces, and we know how many people work there, but we're not really assigning the people that work there specifically to that workplace. We just shuffle it and do it based on a gravity model so that people who live closer to work tend to work in those workplaces. But it's not actually based on who works where, if that makes sense.
Yes, thank you.
Any other questions for Guido?